Okay. All right. So I'm going to go ahead and start. All right. So, okay, good afternoon again, team. Here is my presentation on the multifunctional role of manual percussions and or tapping, utilized as chest clearance and for reducing signs of respiratory distress in the premature patient with respiratory distress syndrome. Here is an outline of my contents. So I'll briefly run through the introduction, then lung development, respiratory complications of the premature infant, neonate respiratory distress syndrome, physiotherapy management of respiratory complications, and then I'll go through tapping for secretion clearance, tapping for neuromuscular facilitation, exploring tactile interventions, the vagal tone, the pain gates, and then of course a conclusion, and I'll open the floor for any question and answers that we may have. All right, so introduction. According to S. Thangavelu, fever and respiratory distress are the most common reasons for hospital visits by an acutely ill child. Physiotherapy acts as an essential part of medical management within the neonatal intensive care unit. And the service includes, but of course is not limited to, chest optimization. And one technique used, and the focus of this presentation, is chest manual percussions or tap, a technique used typically to mobilize and clear airway secretions. From my observation in the NICU, it has revealed that there are some patients that actually respond to this technique with decreased signs of respiratory distress, including but not limited to increasing oxygen saturation readings, and therefore suggesting that manual percussions or tapping may actually be multifunctional. Now on to a brief embryology review on lung development. Now, as we may recall, the human body develops from 3 germ layers, and from each of these germ layers has each of these germ layers has its own derivative. So starting off with the endoderm, the derivatives of same are gastrointestinal and the pulmonary systems. The mesoderm, you have the musculoskeletal and the genitourinary systems, and of course the ectoderm has the integumentary and nervous systems deriving from it. According to ScienceDirect.com, lung development involves lung bud initiation, branching morphogenesis, saccular formation, alveolar septation, and accompanying vascular development that begins in the embryonic period and continues through fetal and postnatal periods. The stages of the lung are divided into the following 5 stages. So there is stage 1. These are weeks 4 to 6 of gestation. Here it is referred to as the embryonic stage. And this is when early upper airways actually begin to appear. In stage 2, weeks 7 to 16, this is referred to as the glandular stage, when the lower conducting airways start to form. Stage 3, or weeks 17 to 28, this is referred to as the canalicular phase, when the acini develop. Stage 4, or weeks 28 to 36, this is the terminal sac period, when the first respiratory units for gas exchange actually make their appearance, and essentially this is where surfactant production begins. Stage 5, this is the alveolar phase or alveolarization phase, if you may. This is when the alveoli, as the name suggests, develop. Now in this image, it is lung development from 4 weeks of gestation to 8 weeks. So as I mentioned before, lung development, you can see it's a bird's eye view of the lung bud initiation, branching morphogenesis, saccular formation, and eventual alveolar septation that occurs in terms of the lung development. If you focus your attention to the beginning of the 4th week, you'll see the laryngotracheal tube. Pretty much it's differentiation, as we all know, it occurs up until the point, the end of 4 weeks, where you have an imminent trachea and you start to see bronchial budding. And bronchial budding continues on until you start to see the bifurcation of the trachea, until upon 8 weeks, you have a definite or a more prominent upper lobe and lower lobe on the left side. And we all know why it's only 2 lobes. And we have on the right side, an upper lobe, a middle lobe, and a lower lobe. And this is just a summarized view of the same image, showing again lung bud initiation, branching morphogenesis, saccular formation, and alveolar septation. So if you really think about it, premature birth predisposes the neonate to a plethora of respiratory complications. Some of these respiratory complications include neonate respiratory distress syndrome, pulmonary hypoplasia, bronchopulmonary dysplasia or chronic lung disease, pneumonia, apnea of prematurity, childhood interstitial lung disease, meconium aspiration syndrome, pulmonary hypertension, and transient tachypnea. Now, the neonate respiratory distress syndrome. What is the neonate or newborn respiratory distress syndrome? From now on, I'll refer to it as NRDS. It commonly occurs in the premature infant who is born less than 28 weeks of gestation. The hallmark of this condition is severely underdeveloped lung and insufficient surfactant production. And if you recall from the image that we had, at this point, surfactant really would just not be enough for these babies. And so what is likely to happen is that atelectasis is highly likely. They will likely have challenges with breathing, decreased oxygen exchange, and because of this, poor oxygenation to support the organ systems. So it predisposes them to a high risk of multiple system failures. Also, work of breathing is increased and they will more often than not become ventilator dependent. Having the RDS or NRDS could also progress to bronchopulmonary dysplasia if at 36 weeks the neonate still requires oxygen therapy. Now, what is the medical diagnosis of NRDS? Sorry. So the doctors or the medical team would order a chest X-ray because they'd like to rule out, of course, atelectasis. Blood tests or ABGs would be done because just to check the oxygen levels, of course, and of course the different blood gases and to see if there is any infection. Echocardiograms would be done to rule out heart defects. The medical management of NRDS includes surfactant replacement therapy, and this occurs typically immediately after birth and or several times for the day until the baby is able to breathe better, or the pregnant mother may be given corticosteroids, and this helps to increase surfactant production in the newborn. Oxygen support therapy is also given. So there is NCPAP or neonatal continuous positive airway pressure, endotracheal tubes, nasal intermittent positive pressure ventilation. These are some examples. Other supportive treatments such as nutrients and fluids, incubation, vitals monitoring, suctioning, open or closed ventilator hyperinflation or VHI position and positioning. So on the left of the screen, you'll see images showing mild versus severe deficiency in the premature neonate. Okay. Now the 3 E's of respiratory distress. The 3 E's of respiratory distress, these are pretty much the signs. Long and short, it's the signs of respiratory distress in the neonate. And they include effort of breathing, efficacy of breathing, and the effect of breathing. So it's very important as therapists, as you know, to be able to point out or to identify these signs. So for effort, is the baby tachypnic? Is there nasal flaring, stridor, wheeze, subcostal recession or intercostal recession? Is there suprasternal recession or sternal recession? For efficacy, you want to look for chest expansion, for the saturation percentage, and also for decreased air entry. For the effect of breathing, you want to check for cyanosis, tachycardia, and or altered mentation. Now, physiotherapy management of respiratory complications are not necessarily only respiratory distress syndrome. Physiotherapy includes, but is definitely not limited to, the manual, percussion or tapping, positioning, suctioning, basal lifts, quick stretches, sustained manual pressures, and or mobility. So tapping is done in physiotherapy, as we know, for secretion clearance. According to Physiopedia, Percussion is a manual technique used by respiratory physiotherapists to improve airway clearance by mobilizing the secretions in one or more lung segments to the central airways. And percussion over an affected area produces an energy wave, which is transmitted to the lungs and the airways. Chest percussion can also be used as a diagnostic tool. So for example, if there is air accumulation, the sound would be hyperresonant. For example, in the case of a pneumothorax, if there is fluid accumulation, the sound would be hyporesonant. For example, in the case of a pulmonary effusion. And this is an image which is all too familiar to us. Chest percussions, infant, newborn to 12 months. So of course you have the different position in terms of postural drainage, different positions for adequate mobilization of secretions, and the use, of course, of chest percussions. Tapping is also utilized in physiotherapy for neuromuscular facilitation. So tapping is the use of a light force applied manually over a tendon or muscle belly to facilitate a voluntary action. Tapping over a tendon would usually be used to assess the reflex activity. A normal response would be a brisk muscle contraction, and Rude recommended 3 to 5 taps over the belly of the muscle being facilitated. This is by McAlfee et al. In 2011. And now, exploring tactile interventions. Generally suggested physiological benefits of tactile interventions include increased vagal tone, increased capillarization, increased temperature, increased oxygenation, and increased tissue elasticity. What is vagal tone? Vagal tone is quite simply the activity of the 10th cranial nerve, otherwise referred to as the vagus nerve. According to wikipedia.org, vagal activity results in various effects, including heart rate reduction, vasodilation and constriction of vessels, glandular activity in the heart, lungs, and digestive tract, liver, immune system regulation, as well as control of gastrointestinal sensitivity, motility, and inflammation. Now, treatments that target the vagus nerve increase the vagal tone and inhibit cytokine production. A study on tactile versus kinesthetic stimulation, comparing tactile and kinesthetic stimulation in preterm infants, showed that tactile stimulation, namely massage, increased cardiac vagal activity, and kinesthetic stimulation decreased cardiac vagal activity. And the tactile stimulation here was massage. It was light to moderate pressure strokes. Exploring tactile interventions, another one includes what is referred to as tactic therapy. Touch and caressing tender in caring or tactic therapy is a unimodal stimulation approach employing systematic stroking to preterm infants in intensive care. Tactic therapy is a gentle or light systematic and rhythmic stroking cutaneous stimulation that follows a cephalocaudal or head-to-toe pattern. Each movement and stroke are given at the same speed with equal proportions of time allowed between each maneuver. One hand is always in contact with the infant's body to maintain continuity. Now, a study by Adamson, Massey, and colleagues, and Royce and Bushnell conducted interrupted pre-test or post-test time series to evaluate the effects of this tactic therapy on 24 high-risk ventilated very preterm infants in a level 3 NICU in London. So the tactic therapy started at 3 days of life, lasting for 3 to 4 minutes, covered whole head and body, and it included gentleness, rhythm, equilibrium, and continuity of touch. The infants were not repositioned during the intervention, and the respiratory rate and oxygen saturation, as well as the pulse rates, were measured before, during, and after. The results included no decrease in oxygen saturation, nor pulse rate, but there was definitely an increase in respiration. Number 2, social stimulation. This is another type of tactile intervention explored. In an attempt to better understand the preterm infant response to sensory stimulation, Oeller conducted a counterbalanced across session study in 15 very preterm NICU patients. This study is actually different from the other touch studies, which I'm going to be mentioning. Why? Because the intent was not necessarily to provide a comforting or soothing touch, but rather to describe the development of the individual preterm infant's responsiveness to sensory stimulation, specifically talking, touching, and a combination of talking and touching. So the results, interestingly, reveal that the infants who received auditory stimulation through periods of talking open and move their eyes more than during the pre-stimulus period. So these same very preterm infants responded differently. They responded differently to being touched by demonstrating more body movement. And we can see where that would be applicable, especially for us as physiotherapists. Patients receiving both methods, the majority demonstrated increased movement. The third tactile intervention that I was able to find is referred to as gentle human touch. So gentle human touch is still or contained gentle touch without stroking, rubbing, or passive movement. Gentle human touch is a skin-to-skin touch contact technique designed specifically for the fragile premature infant. J conducted a quasi-experimental and observational study examining the physiological and behavioral effects of gentle human touch in one of the first studies to evaluate gentle human touch in medically fragile, very preterm infants who were intubated and mechanically ventilated. J provided gentle human touch to 13 very preterm infants by placing one hand on the head of the infant and the other on its abdomen for 12 minutes, 4 times per day, for 10 days, commencing when the infants were less than 96 hours of age. Each of the 13 infants received a total of 48 minutes of gentle human touch per day, and infants who received gentle human touch were found to have had higher hematocrit levels, resulting in fewer blood transfusions and lower oxygen requirement over time, which appeared to be clinically significant compared to infants in a matched control group. Found that very interesting. And now the final one, tactile intervention number 4, massage. A study focused on the effect of a short course of moderate pressure sunflower seed oil massage on the weight gain, velocity, and length of NICU stay in preterm infants showed only 5 days increases preterm infants' weight gain and decreases their duration of NICU stay significantly. This is a study by Tahiri, P.A. et al. In 2017. And the suggestion, in summary, was that transcutaneous feeding is what was being done. So they used oils such as sunflower seed oils, and other studies which were very similar to this made mention of coconut oils. Now, here I managed to see a nurse actually using olive oil on a patient, and I asked her about it because I just read about this study. I asked her about it, and she said no, she's not doing any massage. She's just cleaning the baby with the olive oil. In actuality, these studies, the nurses were actually the persons who were trained to do the massages. So you can see where that might be applicable to out here. It's something to think about. Mechanoreceptors. So the mechanism of action in these tactile interventions that I've just mentioned. So recall the baroreceptors and mechanoreceptors within the skin are innervated by vagal afferent fibers, which constitute the predominant source of afferent inputs to the neurons that give rise to the efferent vagal fibers that provide the parasympathetic control of the internal organs and control the body during rest and relaxation. Mazone et al. 2016 states that the information arriving in the central nervous system from the vagal afferent nerves is largely subconsciously interpreted and integrated into efferent actions, including alterations in the rate and the depth of breathing, as well as increasing or decreasing autonomic flow to the airways, smooth muscle glands, and the vasculature. Now, another point that I wanted to bring across as well is the pain gate theory. I did not expound on this too much. I just wanted to make mention of it. But the pain gate theory could also play a part in why it is that tactile interventions seem to work well for these neonates. So the gate control theory, as we may recall, is a theory of how non-painful sensations can override and reduce painful sensations. And that is the end of my presentation. A brief conclusion. So although there weren't any studies specific to utilizing physiotherapy per se for neonate respiratory distress syndrome, we can appreciate how tactile interventions have been utilized to aid with increased vagal activity and resulting in physiological responses such as increased oxygen saturation, decreased pulse rate, increased respiration, and we see where this is applicable in the patient in respiratory distress. So in some cases, for example, even though these tactile interventions did mention severely fragile respiratory distress patients, there were cases that the tactile intervention just would not have worked on. But surely, it may be, no, what is it? So, and in these particular patients who did not respond well to the tactile interventions, medical management had to be employed here. So the NICU, so the patients now who this would be applicable to are the ones who are mildly to moderately distressed, and only some of which may be in severe distress. So it does not necessarily work for all patients, according to studies. So as we know, the NICU can be described as a traumatic experience for a newborn baby who has prematurely exited uterine life. He or she will be exposed to various tactile stimuli from various procedures, such as pinprick, needle pricks, cleaning, to the gentle touch from the mother or caregiver. And it is important as physiotherapists to optimize the sensory experience then in NICU patients, and tactile stimulation, I believe, is just one of those. And here's my references. And are there any questions?